So macrocytic anemia is MCV, anemia with high MCV. MCV of more than 96 femtoliter is macrocytic anemia. And MCV of less than 76 is microcytic anemia. So macrocytic anemia can be further subdivided into megaloblastic causes and normoblastic causes. Megaloblasts are the cells in which nucleus to cytoplasm ratio is increased. And normoblastic are still macrocytes. Their size is more than 96 femtoliter, but the nucleus to cytoplasm ratio is not that much increased. So anything that lead to impaired synthesis of DNA, that is a part of nucleus, will cause megaloblastic anemia. And anything that does not interfere with the DNA synthesis, but it lead to increase in the size of RBC, they will be included in normoblastic causes. So the causes of megaloblastic anemia is B12 deficiency and folate deficiency, because B12 and folate, both of them are required for the synthesis of DNA. So their deficiency will lead to impaired DNA synthesis, and it will result in megaloblastic anemia. Hypothyroidism, pregnancy, reticulocytosis, myelodysplasia, alcohol, liver disease, all of them will lead to macrocytic anemia, but the cell will not be megaloblast. It will be normoblastic cells. So some examples of non-megaloblastic macrocytic anemia are those in which there is no impairment of DNA synthesis, and the important causes that you need to remember about non-megaloblastic macrocytic anemia. One of the cause is a liver disease or alcohol or chronic alcoholism, liver disease due to chronic alcoholism, and the other one is reticulocytes or reticulocytosis. Reticulocytosis and alcohol disease and alcohol or liver disease, you need to remember these three causes which can lead to normoblastic macrocytic anemias. Why there is macrocytic anemia and liver disease? Normally, what happens in hepatic diseases, that macrocytosis occur secondary to increased deposition of cholesterol and phospholipids on the membrane of circulating red blood cells. Normally, these phospholipids and cholesterol, they are removed from the RBCs, but in liver disease or hepatic disease, the patient are unable to remove these excessive cholesterol or phospholipids in the membranes of circulating RBCs, so it lead to an increase in the size of RBCs, so they result in normoblastic macrocytic anemia, liver disease. While in case of reticulocytosis, reticulocytes are basically immature RBCs. In case of hemolytic anemia, reticulocytosis occur, that is immature RBCs are released into the circulation, and immature RBCs are approximately 20% larger than the mature RBCs. So that's why in reticulocytosis, though there is no impairment in DNA synthesis, but the size of RBC is still higher, on the higher side. So that's why in reticulocytosis, non-megaloblastic macrocytic anemia can occur. What are the investigations that can help us in diagnosis of the megaloblastic anemia? The megaloblastic anemia is due to B12 or folate deficiency. And in case of B12 or folate deficiency, there will be hypersegmented neutrophils found in the peripheral smear. So on complete blood count, there will be low HB and high MCV. On peripheral blood film, there will be hypersegmented neutrophils in both B12 and folic acid deficiency. LFTs will be abnormal in alcohol and in liver disease. Serum B12 level will be decreased in B12 deficiency, and serum folate levels will be low in folic acid deficiency. And sometimes a test that is known as Shilling Test can be done to make a diagnosis of pernicious anemia. In Shilling Test, a oral radioactive vitamin B12 is given to the patient, and then its amount that is excreted in the urine is checked. If there is no absorption of B12 in the terminal ileum due to intrinsic factor deficiency, all of this radioactive B12 will be excreted in the urine. So the amount given orally will be equal to the amount excreted in the urine. So this is how we can confirm B12 malabsorption or pernicious anemia. Shilling test is named after D. Robert F. Shilling for his work on detecting radio quad level vitamin B12 in the urine. So now let's discuss the causes of megaloblastic anemia one by one. So the causes of megaloblastic anemia, there are two causes of megaloblastic anemia. One is B12 deficiency and the second one is folic acid deficiency. So B12, vitamin B12 is found in meat, fish, dairy products. So the source of vitamin B12 is animal source. So vegetarian people will have a deficiency of vitamin B12. Vitamin B12 binds to intrinsic factor in the stomach, and this complex is absorbed in the terminal ileum. So intrinsic factor is released by the cells in the stomach or the epithelium in the stomach. So any problem with the intrinsic factor, the cells that produce the intrinsic factor, it can lead to vitamin B12 deficiency. And any problem in the terminal ileum can also lead to vitamin B12 deficiency because vitamin B12 is absorbed in the terminal ileum. Clinical presentation is same as of other anemias, that is fatigue, dyspnea on effort. Remember that vitamin B12 is required for the myelination of the nerves present in the central nervous system as well as peripheral nervous system. So if that's vitamin B12 deficiency, the patient will have signs of symptoms of anemia, and also there will be neurological symptoms such as peripheral paresthesia, disturbances of position and vibration sense. And if uncorrected, the patient may develop subacute combined degeneration of the spinal cord, leading to permanent ataxia. So what is subacute combined degeneration? Subacute combined degeneration is degeneration of the tracts that are present in the spinal cord because of deficiency of vitamin B12, because vitamin B12 is required for the myelination of the nerves that are present in the central and peripheral nervous system. So if vitamin B12 deficiency is not corrected, it can lead to ataxia. So in short, clinical manifestation of B12 deficiency include chronic anemia, such as fatigue, dyspnea on effort, and neurological symptoms. That is peripheral paresthesia and disturbance of position and vibration sensation. And if not treated, then it can lead to subacute combined degeneration of the spinal cord. What are the causes of vitamin B12 deficiency? The commonest cause or the most common cause of vitamin B12 deficiency is pernicious anemia. Pernicious anemia is a condition in which there is autoimmune destruction of the gastric cells that are responsible for intrinsic factor production. So a deficiency of intrinsic factor due to autoimmune destruction of the gastric cells will result in pernicious anemia. So if the cause of B12 deficiency is autoimmune gastric destruction of the cells that are responsible for intrinsic factor production, then it is known as pernicious anemia. Pernicious anemia is usually present in association with other autoimmune diseases such as hypothyroidism and vitiligo. And vegetarian people can develop vitamin B12 deficiency because vitamin B12 is present in animal sources such as fish, and dairy products, etc. Patient can develop vitamin B12 deficiency after total gastrectomy because body stores of vitamin B12 can last for a few years. So a patient with a history of gastrectomy will only develop vitamin B12 deficiency 1 to 2 years after surgery. So we have discussed the causes one by one, starting from the stomach. That was pernicious anemia, either autoimmune destruction of the cells, that is known as pernicious anemia, or a total gastrectomy, or due to diet, vegan diet in the stomach. Now the third cause is the the B12 is absorbed in the ileum. So any ileal disease such as resection of the ileum, either a history of resection of ileum or Crohn's disease can also cause vitamin B12 deficiency, and malabsorption disorders such as celiac disease or tropical sprue, they can also cause vitamin B12 deficiency. So you can remember the causes of vitamin B12 deficiency, starting from the stomach and then moving towards the ileum. Hematological abnormalities of B12 deficiency, they include macrocytic anemia. MCV is typically M more than 110. MCV is increased in both folate and B12 deficiency. Hypersegmented neutrophils are seen in both folate and B12 deficiency. How can you differentiate between vitamin and B12 deficiency? Because the clinical presentation of both of them is same, that is macrocytic anemia or MCV more than 110, along with low HB and hypersegmented neutrophils on peripheral blood film. The only way to differentiate, there are two ways by which you can differentiate. If in the scenario they mention that the person is vegetarian, then the deficiency will most likely be vitamin B12 deficiency. And if he is non-vegetarian, then it will be folic acid deficiency. And if neurological symptoms and signs are present, then it will be B12 deficiency. And if they are not present, then it will be folic acid deficiency. Management of vitamin B12 deficiency in pernicious anemia, in total gastrectomy, in ileal disease will be IM hydroxycobalamin, because there's problem with the absorption of vitamin B12. So oral hydroxycobalamin is not going to be effective. So IM hydroxycobalamin will be used in the management of vitamin B12 deficiency. Subacute combined degeneration. What is subacute combined degeneration? It is characterized by degeneration of the dorsal column and lateral column of the spinal cord due to demyelination, because as I told you that vitamin B12 is required for myelination of the nerves. So dorsal column and lateral column of the spinal cord will be, and dorsal column is involved in touch and position and vibration sensation. So that's why patient will have paresthesia and loss of vibration sensation and ataxia in case of subacute combined degeneration. The second cause of megaloblastic anemia is folate deficiency. Folate deficiency, the common cause of folate deficiency is dietary deficiency of folic acids. Folic acid is present in the plant sources, so someone with a A non-vegetarian diet will develop folic acid deficiency very easily. Someone with a history of malabsorption, celiac disease, jejunal resection, folic acid is absorbed in the jejunum. So jejunal resection will result in folate deficiency. Crohn's disease can also cause folate deficiency. Alcohol excess can also cause folate deficiency. So alcohol can cause normoblastic anemia, or it can cause megaloblastic anemia as well. So the direct effect of alcohol is normoblastic macrocytosis, and if it impairs the utilization of folic acid, it can also cause megaloblastic macrocytosis. Antifolate drugs such as sulfasalazine or methotrexate, they can also cause.
Which is the common one, does alcohol do? Because normally we see they give scenario like alcoholic with high MCV. So which causes like folic deficiency is the most common for alcohol or the non-megaloblastic one?
The normoblastic one is the more common type present in the alcohol.
Okay, thank you.
The management of folic acid deficiency or folate deficiency is 5 milligram of folic acid for 4 months, orally for 4 months. An important point that you need to remember about folic acid and B12 deficiency is that if someone present to you with deficiency of both vitamin B12 and folic acid, then you will always treat B12 deficiency first, because if you use folate first, then it will mask the symptoms and allow neurological deficit to develop. That's why before treating folic acid deficiency, you need to always check B12 levels before treating folic acid deficiency. Because if both deficiency of both of folic acid and B12 is present, then you will treat B12 deficiency first and then folic acid deficiency in order to avoid precipitation of subacute combined degeneration of the spinal cord, which is a serious condition. So that's why always check B12 levels before treatment. And a diagram is also shown to you of a hypersegmented neutrophils. You can see 2 and 3, 5 and 6 and 8. There are 8 segments of the nucleus of the neutrophil. So this is a hypersegmented neutrophil that is shown in a peripheral blood film.
Sorry, what does that mean? Hypersegmented?
Normally, there are 5 lobes of nucleus of the neutrophils, but you can see in this diagram that there are almost 8 lobes of the 8 segments of the nucleus of the neutrophil. So that's why it is known as hypersegmented neutrophil. Can you see this blue segments that are present in this cell, that is neutrophil? There are almost 8, 2 and 3, 5 and 6 and 2, 8.
Yeah.
So this is a hypersegmented neutrophils that is usually seen in folic acid and B12 deficiency on peripheral smear. So microcytic anemia that is associated with autoimmune diseases is pernicious anemia. What are the autoimmune diseases with which microcytic anemia is usually associated? They are vitiligo and hypothyroidism and type 1 diabetes mellitus. So if a person with a history of type 1 diabetes mellitus present to you with microcytic anemia, you will think of pernicious anemia straightforward, unless proven otherwise. Someone with a history of hypothyroidism, you will think of pernicious anemia. Someone with a history of vitiligo and macrocytic anemia, again, pernicious anemia. For example, as given in example 1, a 44-year-old male presents with tiredness and fatigue. So tiredness and fatigue, they are symptoms of anemia. Her HB is 88, so she has a low HB, and MCV is 125, that is high. Vitiligo is noted on her hands. So someone with macrocytic anemia, and vitiligo, your diagnosis will be pernicious anemia, because pernicious anemia is an autoimmune disease and it is associated with other autoimmune diseases. Another example, a 44-year-old female present with tiredness and fatigue. Again, tiredness and fatigue are signs and symptoms of anemia. HB is 88, low MCV. Sorry, HB is low and MCV is high. She also complains of constipation, coarse, dry skin, hair loss, and cold peripheries. So what is the diagnosis here? Which type of anemia is it?
This pernicious anemia and association is autoimmune hypothyroidism.
Yes, she has features of hypothyroidism, that is constipation, coarse dry skin, hair loss, and cold peripheries, and macrocytic anemia. So it is most likely pernicious anemia. Again, macrocytic anemia that is associated with autoimmune diseases is pernicious anemia. And the treatment will always be IM hydroxycobalamin. Vegetarian with megaloblastic anemia, again vitamin B12 deficiency. And non-vegetarian with megaloblastic anemia, folic acid deficiency. Megaloblastic anemia with neurological symptoms, B12 deficiency. So these are some important clinchers to make a diagnosis of either folic acid deficiency or B12 deficiency. Someone with cane with a history of dependent on cane food, microwavable food with no vegetables, folic acid deficiency. A woman presents with lethargy, raised MCV, low HB, and tingling sensation over fingers. What is your diagnosis? B12 or folic acid?
B12.
Yes, B12 deficiency because tingling sensation, but they are asking about the best investigation. So our answer will be B12 and folic acid levels, because both of them can be present simultaneously. So that's why you need to check both B12 and folic acid levels. So again, we discussed a point in microcytic anemias as well, that someone with microcytosis and normal HB. What will you think about microcytosis with normal HB? Microcytosis with normal HB. Anyone? Microcytosis with normal HB is present in two conditions. One is, yes, excellent. Thalassemia. Which thalassemia?
Thalassemia major?
In
No,
thalassemia major,
thalassemia.
HB will not be normal.
Yes, thalassemia minor.
Beta thalassemia minor, alpha thalassemia
Minor.
minor, or thalassemia trait. All of them can have microcytosis, but their HB will be in normal range. So you have thought of one diagnosis very correctly. And if someone does not have any risk factor for thalassemia, no family history of thalassemia, no cousin's marriage, then what will you think about? Normal HB and microcytosis. Then we will think about polycythemia rubra vera. Normal HB with microcytosis in a person who does not have any risk factor for thalassemia. You will think about polycythemia rubra vera, because polycythemia rubra vera can cause microcytosis due to bleeding, but HB will be normal due to increased production of this RBCs or HB. So alcohol causes high MCV, but usually there is no anemia. So microcytosis with normal HB, there are two diagnoses. One is thalassemia and one is polycythemia rubra vera. And macrocytosis with no anemia, you will think about usually alcohol. And how you will confirm your diagnosis? If this is the case, you will check GGT, gamma glutamyl transferase, and it will be raised in alcoholism.
It's macrocytosis with low
Yes.
hemoglobin.
Macrocytosis with normal hemoglobin.
Normal, yeah. Okay.
Macrocytosis with low hemoglobin is folic acid or B12 deficiency.
Yes.
Macrocytosis with normal hemoglobin or no anemia, then alcoholism. You will confirm it by GGT. And microcytosis with normal HB or no anemia, you will either think of thalassemia minor or thalassemia trait or polycythemia rubra vera.
Right.
So key points in this topic were pernicious anemia is the cause of vitamin B12 deficiency. It can co-occur with other autoimmune diseases such as vitiligo and hypothyroidism and diabetes type 1. It is, and second key point is it is important in patient who is deficient in who has both B12 and folic acid deficiency to treat B12 deficiency first to avoid precipitating subacute combined degeneration of the cord. After B12 levels are normal, then we'll start oral folic acid. Methotrexate can cause folic acid deficiency as well. So the patient in rheumatoid arthritis can present to you with megaloblastic anemia or microcytic anemia or normocytic anemia. All of the three anemias can present in a patient with rheumatoid arthritis. So what are the indication for blood transfusion? Again, if symptoms of anemia and hemoglobin is less than 80, or if hemoglobin less than 70 gram per liter in asymptomatic patient, and hemoglobin of less than 50 or 50 gram per liter or 5 milligram per deciliter in a patient with a history of CCF or ischemic heart disease, then we'll transfuse the blood. So in Plab 1 keys and in Plab 1 keys and in Plab verse, it is written to transfuse blood in patient with the history of ischemic heart disease as 9 less than 9 HB. I don't know about the recent one, but remember that the threshold for blood transfusion in patient with a history of heart disease is 50 gram per liter, less than 50 gram per liter, or 5 milligram per deciliter.
In IH, hemoglobin less than 5, then we'll give.
What?
In IH, like ischemic heart disease, is hemoglobin less than 5.
Yes, because with the heart failure or ischemic heart disease, we need to be careful while transfusion of blood because it can worsen the symptoms of heart failure. So that's why the threshold to transfuse blood in patient with ischemic heart disease is very low. In Oxford Handbook of Clinical Medicine, the threshold in the Med Revision and Oxford Handbook of Clinical Medicine, in both of them, the threshold is less than 50 gram per liter or 5 milligram per deciliter. But in Plab keys and in Plab verse, the version that I have of 2021, in both of them, the threshold to transfuse blood is 90 gram per liter or 9 milligram per deciliter. So I'll go with the one written in the Med Revision and in Oxford Handbook of Clinical Medicine. because sometimes in Plab 1 keys, the guidelines are not updated. I don't know about the recent Plab 1 keys, that what is written in those. Everybody please confirm it and let me know in the WhatsApp group. So we have discussed microcytic and macrocytic anemias now and their causes. Now the next topic is normocytic anemia, anemia with normal MCV. What are the causes of normocytic anemia? Normocytic anemia, anemia with normal MCV, and they are caused by acute blood loss. Anemia of chronic disease are mostly normocytic anemias, but in some cases they can be microcytic anemias. And what are the examples of chronic disease that are associated with microcytic anemias? Who will tell me? Give me
Rheumatoid
example of
arthritis,
rheumatoid arthritis. That's right.
Crohn's
And which
disease,
Crohn's disease?
and
Excellent.
yeah.
So normally chronic diseases cause normocytic anemia. So example of chronic diseases that causes normocytic anemia, they include end-stage renal disease or chronic kidney disease due to decreased erythropoietin secretion. They causes normocytic anemia. Bone marrow failure, renal failure, hypothyroidism, hemolysis. So we discussed in the macrocytic anemia that hemolysis can cause macrocytosis as well. Normoblastic macrocytosis is caused in hemolysis if there is increased reticulocyte count, because if reticulocyte count is more than 20% of the normal, and reticulocytes are large RBCs, so hemolysis can cause normocytic anemia or macrocytic anemia. Bone marrow failure, pregnancy, renal failure, all of them can cause normocytic anemias. Anemia of chronic disease, we discussed some points about anemia of chronic disease, chronic infections such as vasculitis, rheumatoid, malignancy, renal failure, all of them can cause normocytic anemia. In anemia of chronic disease, we all have discussed that there is no problem with the iron. So serum iron will be, free iron is decreased and bound or storage iron is increased. So ferritin will be normal or increased in case of anemia of chronic disease. Pathology of anemia of chronic disease is RBC, deficient RBC production due to chronic disease, for example, infection, inflammation, malignancy, which lead to a release of inflammatory cytokines such as interleukin-1, interleukin-6, tumor necrosis factor, interleukin alpha, and all these chemical, because they decrease erythropoietin secretion and they inhibit the erythropoiesis synthesis, and they decrease the lifespan of RBCs, and also gastrointestinal absorption from GIT also decrease by these inflammatory cytokines. So that's why chronic disease can lead to anemia through these mechanisms. Signs and symptoms are same as of other diseases: pallor, fatigue, and dyspnea with activity. Normally on RBC or on lab result, there will be normocytic normochromic anemia, but sometimes such as in Crohn's disease and rheumatoid arthritis, there will be microcytic and hypochromic anemia. And because the anemias in chronic diseases due to inflammation, so ESR will be raised. This is an important point. Serum iron level will be low and ferritin will be high. So this was all about macrocytic, microcytic, and normocytic anemias and their causes. I hope the causes and these topics are clear.